Good morning, everyone that's just joined. Thank you for um, turning up on a Sunday morning for our contraception meeting. The meeting will start at 11 o'clock. So meanwhile, I've got you all muted. So if you want to sing along for the next 10 minutes or make yourself a cup of coffee, whatever works best for you, that's great. And I will catch up with you at 11 o'clock. Hello, welcome to you, those that have just joined us. We will be starting the meeting in just over 5 minutes' time.
Oh, I am sorry. It looks like I'm the last one here. I'm so sorry. Good morning,
There's no
everybody.
problem. There's no problem, Sue. I've told them that we're going to start at 11 o'clock on the dot.
Okay,
But
okay.
at
Well, that
least
makes me
you
feel a bit
know,
better.
yeah, at least you know you are very popular.
I don't know if it's me particularly, or maybe the sun's not out yet, and once it gets, we'll have a lovely Sunday afternoon.
I think we're going to see some rain this afternoon,
Oh no.
unfortunately.
Okay. Oh well, can't have
But yes,
everything.
I'm going to leave you to get on with this in about 3 minutes. I'm sitting
Okay.
here. I am in the office in Chelmsford in case anyone needs anything.
Yeah, okay.
But I will manage the lobby for you. But as you can see, Sue, you've got 25 people in so far.
Wow. Okay. Thank you, everybody, for giving up your time. It's a big ask on a Sunday morning, isn't it? When you work
It
all week.
Yeah, yeah, and we start. Actually, I'm going to put my camera on now. Let's have a little bit of a dialogue. There we go. So we still don't know for colleagues on the call definitively what the requirement is going to be in terms of the contract. We do know that the negotiations have been taking place with Community Pharmacy England and DHSC. We don't believe that the announced changes to NHS England or to the ICBs have impacted on this. We have been assured that we will find out before the start of the financial year, which gives them a week. Therefore, I think it's likely that the bundling of services, if that is in the contract, won't necessarily be an expectation from the 1st of April. That wouldn't be reasonable, but we are expecting the bundling of services to commence within the contractual year. So those of you that are providing Pharmacy First will also be expected to provide the hypertension service and the contraception service, which is why we're here this morning. I know that there has been a bit of there's been a lot of enthusiasm for Pharmacy First, and for hypertension. There's perhaps been a bit of a mixed bag with contraception, but we figure if it is going to be in the contract, let's make the most of it. So we've been working with Provide CIC to make sure that women requesting repeat prescriptions of contraception and increasingly new prescriptions for oral contraception are offered the choice of going to a pharmacy rather than using up a valuable sort of specialist clinic place for accessing their contraception. So we are working on the theory, if you do have to offer the service, let's at least make it worth your while to do so. And we have run with 3 face-to-face ones now, Sue, I think. So in January 23, and then again in January and March 24. And then this is really either a refresher or a catch-up for as many of you that want to do the refresher as possible. I should probably, actually, I'm singing to the choir here. We've taken the decision not to record the session because I want to create an environment where you feel a bit more comfortable to ask questions, etc. And we will then do the catch up once we know what's in the contract and signpost people through to CPPE. But we do know that there's been a lot of interest in running the local services, because I think CPPE have a certain style. I'm not going to say that there's anything wrong with them, but sometimes it is nice to have input from the local service, Sue, and to have a person that's working through the faculty stuff and not the CPPE stuff. So I will shut up and hand over to you. So you've currently got 42 people in your session, and I will sit quietly in the background and just admit people as and when they come in. Okay, so without further ado, everybody, I'm going to hand over to Sue. There you go. Are you okay managing your slides and things?
Yes, absolutely fine. Thank you.
Okay,
Thank you,
Sue. Thank you.
Thank you, everyone, for joining me this morning. I know it probably wasn't the top of your choice on a Sunday morning. What I'm going to do is I'm just going to share my slides, if I can. First of all, you're going to see my desktop, which, apologise for that bit, which is a little bit congested, as you see there. Lovely. So
sorry, Sue, I'd be having words with you about that desktop if you worked for me.
It reflects my mind that's and my car, that desktop. So I don't know what that says about me, but it's how I work. Yeah, every now and again it gets a cull, and then there we go, it's back again. So what I can do now is just start the slideshow. So I think it's a good, this is sort of a bit of a recap, but there are some sort of new slides that I just wanted to bring in as well, and just sort of discuss sexual health, well, issues that we are coming across at the moment, just to, because I think as fellow professionals and especially in the community, you are likely to see some of these people as well as ourselves. So I've put the title as a contraceptive assessment, and it is sort of a bit of a recap. We have got 2 hours. I can't think for 1 minute you're going to want to listen to me for 2 hours, and I don't think I've got enough to say in 2 hours, but hopefully if there's any questions that you have and we can keep it a little bit more interactive, that would be amazing. I don't mind people putting questions in the chat or just putting their hands up, and I'm happy to speak to people. So my name's Sue Luty, and I've got a grand title of being the Essex Sexual Health Service System Lead. And although it's a strategic role and an operational role, I still do clinics. So I do at least once a month. And I think that's really important because it keeps your skills updated, but it also keeps your ear to the ground and you're listening and to the staff and to the clients. So you're sort of keeping up to date with the issues that people are coming across. So I think the objectives for today would be a safe, friendly, patient-focused assessment, looking at safeguarding as well, and an overview and recap of oral contraception. So the last time that I did this presentation, I did have a wingman with me who works, Diane, who works in a young person's service in Tower Hamlets. Unfortunately, she's in Devon this weekend, so was unable to help me today. So some of the slides that I do present are hers, but we've worked closely together in the past, so I will go through these. But I think this was a really good slide to start with because I think it just reminds us how pivotal community pharmacies are to the community. Especially some county as large as Essex, because there's just no way that we are able to have that coverage with our present workings, the way we deliver our service. And these findings were really interesting. I know it's from 2022, but I suspect if we did it today, they'd be very similar, and it may even be higher percentages of people feeling more comfortable coming to pharmacy. So certainly, of the majority of people do say that they would rather go to a pharmacy to access contraception. They'd feel more confident doing that. So I think that just gives the evidence that the new initiatives to provide initiation and repeat contraception within pharmacies is what people want. It's what the community want. So I think this was Diane's slide, but I think from that initial consultation, pharmacists do it better. You're already working with these people. You've got that warm, welcoming, non-judgmental approach. You're seeing the people for various conditions or just to come and browse in the shop. So you've got that sort of individual approach to public health and literally within the community. Generally, you do, I believe, have that private space that you are able to speak to people privately, and you can consider the wider public health issues. You may well know that individual, so you may well already know what other medication they may be on or what other health issues they may be. And because you're in that community pharmacy, you may well be offering other other public health interventions like height, weight, blood pressure, smoking cessation. So you're giving that overview. And because I think it's local, there's one on every high street in the country, I would argue. Then there's a base for people to come back to, and you've got wide range in opening hours, and there's generally a pharmacist open on a weekend somewhere in locally. So with that, with the initial consultation, so some of this is very much young person focused, but it doesn't have to be, because I think some people have these vulnerabilities but don't happen to be a younger person. So I think when you first have that initial consultation with an individual, it's very personal to them. You can't just group people into, oh, they want this, they want that. They will have their own individual needs, and the success of contraception is finding that method that is going to suit them. If it's not going to suit them and they don't think it's meeting their lifestyle or their needs, they're not going to comply with it, and there's either going to be a failure, and they become disillusioned can become disillusioned with contraception. So we offer, and I'm sure you offer as well, we're an inclusive service. We don't want to make assumptions, and we don't want to pass judgment on people's lifestyles. And I think when you do that initial consultation, I know from my own personal experience, it will be with they, them. So I will never presume that what gender they're identifying is, not because I want to make everyone feel uncomfortable. I just don't want to make any presumptions. So that's probably something just worth remembering, because I think if somebody is gender neutral, the fact that they're picking up that you're not presuming anything makes them feel safer, and maybe they are more likely to disclose things moving forward. And I think Diane's put here, culturally sensitive, and I think that is important. It's something in the clinics we do struggle with sometimes. We're not always able to offer the gender of choice for a consultation, but we do try our best, and especially if we know that we're going to do an intimate examination, if it's not urgent, we can actually rebook that person if we haven't got the gender of choice available. We've highlighted some of the sort of legislation around competence and young people and Mental Capacity Act here as well, because I think during that consultation, you are making that initial assessment of competence and capacity, whether it be a younger person or an older person. So I think it's important just to have that in the back of your mind. And if it is a young person, they're not necessarily going to tell you everything about themselves in that first consultation. We tend to find that if they feel safe, if they liked the experience of coming along to the clinic or to the pharmacy, they're more likely to come back and for their repeat consultations, or if they have had a mishap and need emergency contraception, they'll remember how they felt coming into that place and know it was safe and non-judgmental. And I think professional curiosity, I think it's a really undervalued, softer skill that we have. And sometimes some things just don't sound right. I mean, it may be that a young person comes along and milling around in the background, you see that there's somebody older with them. You presume that may be a parent or a trusted aunt. It could be somebody that's got some malicious relationship with that individual. And so sometimes it's just that instinct and that curiosity. You may not feel confident at that moment to breach that, but if then that person comes back there with the same person, those are the times that you just make some gentle inquiries. Oh, has your parent brought you along today? Or some things like that. And also we do appreciate you are in a busy pharmacy. You don't have any control of who's coming into your pharmacy or how busy it's going to be on a day-to-day basis, where certainly within our clinical situation, we're able to we don't have walk-ins unless someone's really vulnerable. They obviously can walk in and we will see them at some point, but all of our appointments are sort of set because that's how we can manage our staffing capacity. So we've put here counselling, but I think that's in the loosest term, really. I think this is just all part of the assessment. And like Diane's mentioned here, developing that rapport with the individual. And it really is trying to listen to them. And I know time's tight when we're doing these consultations, but we've noticed a dip in especially younger people under the age of 25 actually opting for hormonal contraception. I think this generation of predominantly females will not remember the swinging 60s and the sexual revolution where sort of our probably parents or grandparents went through with the introduction of the pill. So they've got no understanding of what life was like without hormonal contraception, and that people had to just rely on barrier methods, either the diaphragm or condoms. And before that, there wasn't an NHS, there wasn't free medication and contraception. So young women now are much more in touch with how this medication is going to make them feel and what is it going to do to them. I think we deal with a generation of people that get their health information from social media. Their influencers are really important. We just need a little bit of a bad press from one of those influencers around hormonal contraception, and that we then are on the back foot. We are having to sort of try to defend the benefits of contraception. The main one being pregnancy, avoidance of unintended pregnancy. But I think if we can have an understanding of where they're coming from, then we can meet them halfway. And so I think by listening to what their issues are and what's important to them, we may well be able to sort of guide them by saying, well, actually, the contraceptive pill Some of them are skin friendly. The bleeding that you, if you choose to have bleeding with your method, it is going to be reduced. You're going to have less pain when that happens. There may be some relation to mood, and if you have a detrimental effect to your mood, then we can swap that contraceptive method, because the mood, the hormone related to mood changes is more likely to be the progesterone. So we can swap the progesterone within that. If it's a combined method, for instance, we could swap that around. So it's letting them know we empathise and we understand where they're coming from. But if they're choosing a reliable method of contraception, the hormonal route is probably the best for them. And the preference for different regimes. We don't have to have that set 28-day bleed anymore. We can tailor. They can tailor the way they take their combined pill to their lifestyle. So they can take it, try cycling, take 3 packs, one after each other, and then have a break. What we would say is that break you can just do that for 4 days now. We don't necessarily have to have that 7-day break. And all of that is based on some research that has shown us that during that 7-day pill-free interval, that traditional method of taking the combined pill, some women developed ovaries. There began to be some activity, and they believed it was as high as 1 in 5 women would actually then go on and ovulate. So despite the fact the woman would start their regime on after a 7-day break, as we've told them to, they may well still be at risk of pregnancy from that. So that's why some of the regimes have altered. So again, it's talking to the young people or to the women that we're seeing, and how this would fit in with their lifestyle. We would discuss all the methods and how effective they would be, how they work. I think once you start talking to individuals, you will get this understanding that actually they have very little knowledge of their body, of how their cycles work, of the biology really, and not expecting that they should know that, but it does help. It does help moving forward if they've got that understanding of how the pill will work, because of how it's actually impacting them. If they suddenly realise, well, actually, the pill is stopping me from releasing an egg, then they'll just realise that that then means that they're just going to that's how it's preventing them from getting pregnant. So that's certainly one of the things that it's worth sort of talking through. And then we would go through the risks and benefits. And of course, all of the methods of contraception, apart from the condoms, are not going to prevent STI transmission. And it is one of those pointers that we do speak to people when they're coming in to discuss an assessment. I mean, it could be that these people are in monogamous relationships and that's why they're choosing to choose a hormonal method, but that may not be the case, and I don't think we can always presume that will continue to be the case. So it is just worth mentioning that with them. And around consent, and again, these extra bits may not be what you have time to discuss that initial consultation, but it's just some added things just to be aware of. Are they in a consensual relationship? Are they at harm? And maybe some discussions around gender if that became something appropriate during that consultation. So I think this slide, although it's really busy, and I apologise for that, it's quite difficult to make sense of. But basically, this is just sort of a reminder for ourselves as well, really. What is the risk of getting pregnant? Are you okay there, Karen?
Yeah, sorry,
Right.
Sue, just to jump in. Will we be
Yeah.
able to share these slides with people? Because I know they're going to us.
Absolutely. I
That's
will
great.
send them a lot.
That's all.
Yeah, yeah. No,
Thank
that's
you.
fine. Thank you. Yeah, it is a bit busy, isn't it? But it's definitely worth I sometimes just look at this every now and again and go, oh yeah, that's how it is. Because really, you can have no method, and in a year there's an 85% chance you're going to get pregnant. And sometimes these are the things just worth speaking to to the clients around as well, the fertility-based methods, the condom. You know, the condom and the diaphragm, they're reasonable methods of contraception. And then we get down to the hormonal methods, as you can see, and with perfect use, these are really effective methods. Our LARC methods, obviously, we try to, we don't push people anywhere, but we try to guide. We, during our consultation, even if it is for the contraceptive pill, we will mention LARC, the long-acting reversible methods, because I think it's just worth them having that in the back of the mind. If actually, well, I'm finding it a bit annoying taking a pill every day, there is something else. It's always worth them knowing there are alternatives to the method that they start with if it's not found to be suitable for them or things change. So I think one of the most important things for us as a professional is our baseline observations of that individual as they present within the service. And so we would do some baseline observations. It is common practice in our service that they would be done straight away. So they would be done even before the clinician has seen the client. And at that point, some people are quite anxious. They're in here. They don't really want to be here because it's all a bit weird in our clinic. So their blood pressure and pulse may be a little bit off kilter there. So although they do the baseline observations, I always just keep that, if the blood pressure is just a little bit higher than I would like it to be, then I'm going to recheck that. I won't just take that as the baseline, because I think once you've been through the consultation, you've built that rapport, you've been through everything, they've relaxed a little bit, and then we can move on. So that's one of the most important things. That gives you that baseline of what you're starting to think might be more suitable for that individual. So if the blood pressure remained high, then if it was over the baseline recommendation of 140 over 90, then we'd be starting to think, well, actually a combined method wouldn't be the best for this individual, the safest. So we're more likely to be looking at a progesterone only method. And then we're looking at obviously allergies, we would all do that. And we'd look at their medical history and their sexual history. We want to know when their last menstrual period was. We'd like to know when they last had any sex that wasn't protected with a condom, because do they need emergency contraception first before we start, that we could quick start with an initiation of a combined pill. If they're coming back for repeat pills, have they missed any of those? Is there any risk of pregnancy? Are they breastfeeding if they're postpartum? And how many weeks postpartum are they? That all of those things will indicate what we're thinking is the most appropriate and safest method for them. We would look at their family history, and this can be quite difficult for people, especially when they weren't expecting us to start asking about sort of mum, dad, brothers, sisters' health. But obviously it's certain things that we're wanting to know about. We're wanting to know a sort of cardiovascular disease, especially under the age of 45, and venous thromboembolism risk as well. So and it can be very difficult for younger people to know that about their parents, because their parents are probably younger than 45 anyway. So that can be tricky. And then I would sort of say, well, how are your grandparents? Is there any health conditions your family have talked about that run through families, if you like? And also around any medications that they're using, and including sort of medication they can take over the counter, sort of St. John's wort. And there is the smart medication, which is the name has completely gone off me, that some young people use during exam time. I can't remember the name of the drug. I will get back to it. And that can interact with the oral contraceptive pill. And sort of we do a brief intervention around lifestyle as well, and this is sort of building a picture of this individual, and that would be around sort of smoking. We don't have any data around vaping and its impact on health at the moment. I suspect at some point in the near future that will come up as well. At the moment it's just cigarette smoking, but I guess any time for an intervention around vaping and the potential issues that it may form with lung health. recreational drug use. Again, we ask about smoking weed because they tend to, that gets mixed in with tobacco as well. Alcohol, eating disorders will have already got their BMI from the baseline observations, but all of this is just building this picture. And at the same time, we are able to signpost to other services during this point. So we've got contacts with the Essex Wellbeing Service. If there was something around recreational drug use, especially sort of around chemsex, we've got agencies that we can refer individuals to. So we're taking that holistic view of that individual. So our Bible within the clinic, and I know Karen mentioned your own governing body there that you derive from your educational input. For us, it's the Faculty of Sex and Sexual and Reproductive Health Care. It's who we do our training through, and it's where we get our letter of competence to be able to do implants and coils, and we can be we do extra training to have the diploma, and we can become faculty trainers. So there's lots of training that comes from there. And there's also the UK MEC eligibility criteria. I'll sort of hold it up. You can download this. I actually am a really old fashioned and like a book, so that I can, so this comes with me and it's got tea and coffee stains on it. And I think that just shows how well used it still is, because things do change. This is from 2016. We get updates from the faculty as things do change, and I'll go through there's a little highlight that's a few slides further down, where they bring out new statements for when new research and evidence has become available. So I would really promote being involved with the faculty. You are able to join that, and you are able to do some of their educational courses on there, sessions on there. They also have all the printed guides for emergency contraception and all the relevant contraceptive guides as well, and the drug interactions. All of these things we find really, really useful, and we use them all the time within clinic. So with the UK MAC, they've got this eligibility criteria, and it helps us to guide whether or not an existing health condition with that individual is the method that they want is suitable for them. And what we really want to see is that any health condition they have is a category 1 or 2, and that would indicate that any condition that they have, the advantage of using a contraceptive method will outweigh any theoretical or proven risk. So I'm just going to quickly have a look at my book so I can tell you something. So this is around the combined pill. So after 6 weeks postnatal, a female in the postpartum, after 6 weeks, her risk would fall into a category 1, so she could start the combined pill because the risk of VTE has dropped significantly. But if she was less than 3 weeks, that risk factor would be a 3. So if you can see a category 3, it's a proven risk where the risk would outweigh that benefit. So in this particular woman's case, we would advise she starts the progesterone only pill, because we know that would be a category 1 risk, because it's not known to impact the risk of VTE postpartum. So this is how we work within the service, and we find it really helpful. Sorry, Karen.
Yeah, no, just to let you know, I've put in the chat the link to the UMEC calculator online.
Wonderful.
And that
Thank
should
you
answer
so
all the
much.
questions. Okay.
Thank you. Fabulous. So red flags, there are things that you go, oh heck, yeah, that's not good. And I think one of the most common ones we get is migraine with aura, because we start that question with, have you ever had, do you have any issues with migraine? Have you had, oh yes, I get them all the time. And so what we've got to do then is unpick that migraine with aura, because this is something very specific, as you know. I know you're all aware of this, but for us, that would be a red flag. So that would, if we can drill down and get actually what symptoms happen. What happens before your headache come on? Do you get blurred vision? Do you get some change in sensation? I'm one of these individuals that does use, well, still occasionally get one migraine with aura, and the first time it happened I thought I was having a stroke. I literally did get the weakness in one side, and I the vision and everything, and then 5 minutes later vomiting, headache. So there's something very distinctive, and it's a shame that we don't get to drill down with this one as much as we should, because if we misdiagnose that or decide we're not going to take the risk of not not prescribing that, that woman then has a lifetime of not having that option of a combined pill. So I think if certainly within clinic, if we don't feel confident with the answers that we've received, then what we will do is refer that person on to one of the doctors or one of the more experienced clinicians to make that decision. In the meantime, we'd start them on a progesterone only method or a LARC. So smoking over 35, more than 15, again, that would be a red flag for us, and it would discount having the combined pill, but not the progesterone only method. And hypertension. So even if it's controlled with antihypertensives, if the blood pressure is still highlighting 140 over 90, that still would be a reason that we personally wouldn't feel happy for them to commence the combined pill. And I've got the others there for you to look at as well. So one of the new updates that I've mentioned that the faculty have do release, and this is really new. This was from February, so only last month, and it was really pertinent to us because we have started to get lots of inquiries about the weight loss injections. People have, because they're purchasing them themselves, they're not getting maybe some of the information that they probably could have had, and so they're not understanding that there is a potential impact of having the weight loss injections with their contraceptive pill. So the faculty, this is the patient information leaflet, and you can print these off and download them for your clinics, for your community services. But it actually is really helpful, and it tells the clients what the risk is, and the risk is because of these the antagonists. They actually they increase the gastric emptying, slowing the rate in which the food, so it delays the gastric emptying, I beg your pardon. So that would delay the contraceptive pill actually being absorbed and processed. So the only one that we think has got that issue is Monjaro. It does seem one of the more popular ones. So in that case, they would be advised to use barrier methods for 4 weeks after starting the Monjaro injection, and then after each increase in dosage. So in those cases, it may be that it's worth considering another method while they are on the weight loss injections. But with the others, sort of Ozempic, which is one of the most popular ones as well, there doesn't appear to be that risk. There could be a risk with all of them if the individual has side effects of the diarrhea and vomiting, because that can be one of the most common side effects. And again, if that would be if the patient vomits within 3 hours of taking the oral contraceptive pill, or the diarrhea is really excessive and goes on longer than 24 hours. If that was the case, again, it would be looking at the missed pill rules. So if they may need to use barrier methods until they've got the 7 days back in their system after that incident, or just think of another method, switching over a other method while they take the weight loss injections. I mean, it's really quite important because they are advised to use a reliable method of contraception while taking the weight loss injections. We are not sure of the impact on the impact on a patient who does fall pregnant with the injections, and what that possibility has for any fetal abnormality. So at the moment, they're saying to have a really reliable method. But interestingly enough, it is just the oral methods of contraception that are impacted. So they can move over to the patch So Evra patch, if that's the one that you have in stock, or the vaginal ring, or move over to sort of Depo-Provera injection, or think about the LARC. So it literally is just the oral methods that are impacted. But we found this really useful to hand out to some of our clients, and we have it on our website as well. So I'm going to move on to sort of the safeguarding aspect, because I don't know how you all feel around safeguarding and under 16s requesting contraception, but it is something that within our service, you know, it still can cause us some anxiety, and we feel we've got that responsibility. It's almost like we're taking over some sort of parental role, because the majority of these young people will not come with parents. They're taking their sexual health independently, and they're coming across and asking for our support and help with that. So we do find that, you know, something that we take really, really seriously, and try and do the best for these young people. So I think the first thing is age and competency. I mean, we as a service we have we are able to offer contraception over the age of 13, and that's the legal age that, although it's not the legal age for sexual activity, any sexual activity under the age of 13 is statutory rape. So over the age of 13, there's a grey area between the legality of sexual activity, and that would be taken as an individual disclosure, if you like. And certainly if the partner is within a similar age range, safeguarding would have that as a low threshold to investigate any issues raised around sexual interaction at that sort of under the age of 16. If there's a big age range, so if we've got a 14-year-old that discloses her sexual partner is 18 or 19, that would be starting to ring some red flags with us, and we'd want to dig a little deeper with that, because there's just that age range that doesn't feel comfortable, and it's probably something that we'd want to discuss with the young person a little bit more and discuss with our safeguarding leads. And they don't have to tell us everything. We do find young people are quite savvy, and they do know the law. They do know probably what we're going to ask them about their partners, and we can only rely on what they're going to tell us. And I think that builds that trust, because they think, oh, this person's listening to me. This person isn't going to lecture me about that I shouldn't be having sex under the age of 16. They're treating me like an individual, and that I'm able to have some input into my own medical needs, really. But we keep that professional curiosity, and we just listen, and we just make mental notes, or we do an assessment that is based at the moment on the spotting the signs template. So we're asking questions around school attendance. We're asking questions about this person they're having sex with. Are you being forced to have sex? Do they make you feel uncomfortable if you say no? Can you say no? Do you feel confident enough to say no? And are you using contraception? Are you being given alcohol before you have sex? Or are you being paid to have sex? And, you know, these are the little clues that we can sometimes pick up risk of exploitation, which we have done in the past. And you can build a picture. Some of these groups of young people, they know each other, and they may drop names of individuals. Oh, I hang out with Zoe and Claire, and something might click a few months later that Claire pops in. And so you can build a picture, a mapping, if you like, of risk, but without probing too much. You're just using your professional curiosity. And again, vulnerable adults, um, we sort of have to ask that question. We are probably still one of the only services that ask every individual that comes into our service, do you feel safe at home? Do you feel safe in your relationships? Are you of any harm? And we do sometimes get the blank expressions back and say, why are you asking me this? This is a weird question. But then when we explain, well, actually, some people never get asked that question, and we might be the only people that do, and that opens up some dialogue, which again has happened. And you don't, it's a difficult one because when you ask it, you can't unask it, and you might not like the answers that you're going to get. And I know from personal experience, somebody did disclose that they're a victim of domestic violence, and they don't want to go home, and that sort of triggers all of the rest of that. But that's one of those opportunities that we have, and it does not happen very often. But I don't think that means that we shouldn't be asking it. And of course, how we deal with disclosures, and you'll have your own pathways, what would happen if someone discloses something that's concerning within your service. And we do, we've got our own safeguarding leads and safeguarding team, and we all are able to make referrals into the young person service. We are at the moment in trying to map out a pathway for under 13s. As you may notice yourself, there's a societal shift at the moment, which means that younger people are exploring parts of adult life, whether it be substance misuse or pornography or sexual activity. And there's a gap in services to support these people, because really that shouldn't be happening, so we shouldn't be having to support them. And so we're trying to make a pathway where if somebody does disclose and they're 12 and they disclose they've had sex, thank God they have disclosed to somebody, but what are we going to do about it? So at the moment, that's something that we're looking at. But that would obviously involve a safeguarding referral, and it involves a referral to the police as well, and an involvement of the SARC services. So I think it's good to have just knowledge of what your pathways are and what you would do if something did be disclosed, and then there's not this panic that can sometimes happen. Generally happens at 7 o'clock on a Friday in our experience. And contextual safeguarding. So we do come across these grey areas, and it's a time sometimes when our own personal beliefs and cultural beliefs can be challenged, because ideally, these are children under the age of 16 in our eyes, but they don't feel like they're children, but they are. And so sometimes it is contextual safeguarding. If we've got two 15-year-olds that in their eyes are having consensual sex, they've taken the decision to come and try and find a reliable method of contraception because they don't want to have an unplanned pregnancy, then that has to be looked at and applauded and supported. So yeah, as it says, what is the priority here? How are we keeping this young person safe and healthy, if you like? And one of the sort of questions I do ask is, can you speak to your parents? Can you speak to your mum? Is there someone at home or an auntie that's trusted, or an older sibling who you can have these conversations with? Because it does sometimes make us feel a little uncomfortable that we send home a 15-year-old with a combined pill because of the potential risks. Although they're very, very low, it would be ideal if an adult knew what medication they were taking. So I'll move on to the individual methods. Please just shout if you need to sort of ask me a question, or we can save them to the end. It's fine. So the progesterone-only methods, they've come a long way since the sort of basic ones, which were probably the second generation, certainly in my own experience. So all we would have as a progesterone-only method would be northisterone. And this was the one that had to be taken within a 3-hour window. So it was taken continually, but if they were more than 3 hours late, there was a risk of pregnancy, because it didn't stop ovulation. So it would only work by thinning the lining of the womb, of the endometrium, and the mucus plug at the bottom of the cervix. And although it was popular with some women, and if they couldn't use a combined pill for whatever reason and they still wanted an oral method, then it was really successful for them, as long as they kept with that window period. We have moved on, and certainly desogestrel has had a big impact on our prescribing of the progesterone only methods, because it in the majority of women it prevents ovulation. So we have a bigger window period for missed pills. We've got a 12-hour window period now. So that has opened that up to maybe younger people, who the 3-hour window, if they could oversleep by 3 hours at the weekend very easily if they were taking it on a morning. So this is yeah, revolutionized the progesterone only method, if you like. It's taken continually every day. It can give some irregular bleeding initially, but that bleeding over time tends to settle. So if we were going to initiate a progesterone only pill, and particularly desogestrel, we would advise them they may well have this irregular bleeding, and it will be annoying if it happens. But if you could bear with it for that 3 months, come back and see us in 3 months, and you should notice it will have either stopped completely or it's a lot less. And if you continue with that method, you will find you will not bleed at all. So it can be really successful with that. And then we move on to some of the 4th generation combined progesterone only pills, and certainly the drospiridone is one of our newest progesterone only pills that we have. We haven't used it very much within clinic at the moment. We are starting to stock it more widely. I think for us the issue is around the 7-day start. So for us, a progesterone only pill, and this is just for us as clinicians, was very useful for quick starting after emergency contraception. So if somebody came in and they were within 72 hours of the unprotected sex, we could prescribe levonorgestrel and then as an emergency contraception, and then we would quick start them straight away with the desogestrel. So although they would have to use alternative methods for 2 days, we knew that was more likely, especially within the younger population, more likely to kickstart, and they wouldn't be at any further risk for the next 3 weeks till they can have their pregnancy test, and then continue with the method if they were happier with it. And with drospiridone, that would be 7 days. So, but it does have its place, and we do know that it could be really helpful with skin issues, because that can be one of the drawbacks with the desogestrel, the 3rd generation progesterone only pills. It can have some impact on skin, and that can be quite upsetting, obviously, for people. So if there isn't any contraindications, then with a progesterone only method, they're very few and far between, and it would be more likely to be sort of around a current breast cancer or sort of current hepatic condition. So one where with quite a serious contraindication. For most women, the progesterone only pill is safe up until the age of 55, regardless of a lot of health conditions. So it can be really, really useful, especially for younger people, but for older women as well, especially as they go in towards the perimenopause and towards postmenopausal. So when can we start it? Well, can pregnancy be reasonably excluded? And I think all we can do with that is do a pregnancy test if you're able to, and listen to what you're being told. And if they've not had unprotected sex since their last period, then we can be reasonably assured that they're not pregnant at that moment. So we can quick start the progesterone only pill, and we do that on most occasions, because I think for most people, they want the reason they've come for that method is they want to start that method, and they generally want to start it now. Especially within our service, by the time they've waited for that appointment, it could have been a few weeks to a month. So they would like to start that straight away. So that's what we would do. If there had been if pregnancy couldn't be excluded, but they still wanted to start it and their pregnancy test was negative at that time, then we would still start it, but with the proviso that they would do a pregnancy test when it had been 3 weeks since their last unprotected sex, because we know it's unlikely to have any impact to the developing fetus. Oh, sorry. Have I? Can you still see the screen? Lovely, thank you. It's unlikely to have any impact on a developing fetus for that few weeks. Research, no evidence is there to prove differently. Ideally, no, but and again, it would be speaking to the individual. You want to start it straight away. You have had sex. You are able to do that, but you must do this pregnancy test, because the sooner you know if you're pregnant or not, the sooner you can make a decision what you want to do with that pregnancy. And if the patient wishes a regular bleed, so some people do like that bleed. It assures them that that they are not pregnant. It doesn't really, and you can, again, that's an area to explore. But some people still like to have a bleed. We can't guarantee that that's going to happen, particularly with the progesterone only method. And we would go through how to start the method, how it's going to work. So again, that's the mode of action. With desogestrel, for the majority of women, it will stop them releasing an egg. It stops ovulation. So that's how it's going to stop you getting pregnant. It also thins the lining of the endometrium, so a fertilized egg is less likely to implant. But you've also got that increased mucus plug at the bottom of the cervix, so sperm are not likely to be able to penetrate through that. So you've got a 3-way defense with that. And that's why they need to have 48 hours, so to take the pill for 2 days for it to become effective. And that allows that mucus plug to form before the other actions of stopping ovulation and also the thinning of the endometrium. But that's also the reason why we've got that 12-hour window, and with northistrone a 3-hour window. So if the woman, the individual misses the pill for more than 12 hours, then there is a risk that mucus plug has started to come away and there could be a risk of pregnancy. So this is the sort of information that we do give around how to take the method and what to do if they miss a pill. So if they're more than 12 hours late, they should take it as soon as they remember, take the one that they were going to take that day anyway, and then use condoms or abstain until they've had their 2 days of the pill to get back into the system. If they've had unprotected sex within that time that they've missed the pills, then we would advise that they may well need emergency contraception. So to contact our services, and then once they've had that, restart the pills as well. But there is more information on the guidance documents that we've got on there from the faculty. So the risks and benefits. So the risks are really low with the progesterone only pill from a health perspective, but there sort of are changes that women might notice initially when they first start, and we've got the list here. And they're not. Some women can really feel these. Some individuals appear really sensitive to hormones, and from one woman saying that they haven't noticed any changes whatsoever. They love the method, it's brilliant, they're not bleeding, and they're not getting pregnant. It's fabulous. Just remember to take it every day. Brilliant. For other people, they do have these issues, and although we try to reassure people that the majority will settle within a few weeks, certainly within the within regular bleeding, we would hope after 3 months that has settled, but there are no guarantees, and for some women it does become something that is impacting their well-being, and that means we've got to support them with that, and try and think of an alternative. Certainly with the changes in mood and libido, that is documented as a side effect, and that can have a big impact on people. And again, we'll have already said that that might be something to look out for, but have that awareness, but see how it goes, see if it settles. Changes in weight, it's less likely, but for some women it does. And I think the last thing we say to people is, oh, well, no one's ever said that before. And I have heard colleagues in the past say that, and that makes you feel really uncomfortable, because it's irrelevant what other people have said, because that's how they're feeling. But the benefits, and there are loads, apart from preventing unplanned pregnancy, it can change women's lives. Certainly if they've got menorrhagia, dysmenorrhea, and this is generally why a lot of younger people will want to access hormonal methods of contraception. It's not necessarily that they're sexually active, it's because of the issues with their periods. As a service, some of our colleagues work within PGDs, so they wouldn't be able to support these young people with that, but a non-medical prescriber or our doctors certainly would, because it's going to improve their life. So that's what we can support with. And with the drospiridone POP, it is hopefully going to help with acne and with skin issues. And it can help with hirsutism and weight gain for some individuals. So there are definitely some overall health benefits, as well as the prevention of unplanned pregnancy. So we'll move on with the combined contraception. Again, this is a recap, really. The combined pill still remains the most common hormonal contraception that we see, which is one of the reasons, well, not one of the reasons, but certainly a great reason why we are signposting across to yourselves, because we do still have a lot of women accessing our service for the combined pill. And although it is available in other ways now, I think we probably aren't the most appropriate service for repeat pills. Because generally these individuals are really compliant with their method. They know what they're doing. They're tricycling when they go on holiday. They have it sussed. They know it. They suit it. They don't want to have to ring up, book an appointment that's going to take them probably a month, and then sit and wait in one of our clinics, and then just go through, oh, everything's fine and I want my pills. We can prescribe up to a year now, which has helped. We can post medication out. We can do a virtual consultation if they've had their blood pressure checked within the last 12 months. So we've put things in place to try and support women. But we know they would much rather go to yourselves and just walk in rather than have to wait for us. So yeah, it would be really helpful for ourselves and for the women themselves to be able to access this through community pharmacies. So it is still really common, and if there's been no contraindications highlighted during that consultation, again, you can only make that judgment on that consultation. It may change over time, so that's why it's really important that we complete a consultation on every single attendance, because those changes might not seem important to the individual, but it may to us, and especially if as they age, once they get to 35, and if they're still smoking. So it is a life course assessment, really, with women. So we can quick start. So again, it's pregnancy. Can it be reasonably excluded? And certainly when I started within contraception, we wouldn't quick start a combined pill because we were uncertain about the impact on fetal abnormality and the pregnancy. So it wasn't something that we would do. And ideally, No, but I think if in that situation for that individual, if they were likely to just continue having unprotected sex if we didn't, then we can. So if we do a pregnancy test or they've not had any unprotected sex since their last period, yes, we can be reasonably sure that they're not pregnant at that moment. So we can quick start the combined pill. Again, with the proviso to do a pregnancy test when it's been 3 weeks since they've started the pill or 3 weeks since they had unprotected sex. And again, we can quick start that with the emergency contraception as well. The disclaimer with that would be, of course, would be ELA-1 because of it's a progesterone blocker, receptor blocker. So if somebody's going to have ELA-1, iloprostol acetate, then they have to wait the 5 days before starting either quick starting the progesterone only pill or the combined pill. Sorry, I seem to be talking a lot. So, which I am. So we've got the different types of pills. There are dozens of different combinations of combined pill. And I think sometimes as a clinician, when we're initiating a combined pill, this can be a bit overwhelming because there is such a choice. The faculty would would recommend that we start really on a 35 or less micrograms of estrogen within that pill. So although there are higher ones, they can go up to 50 as we've got on here, that wouldn't be a recommended starting sort of dose for the estrogen element of the combined pill. And that's obviously due to the risk of VTE, because probably for most people you're going to start that pill with, they won't have that background history if their parents are still quite young or they haven't got the history, and also around the breast cancer risk as well. We do know there is a slight increased risk around the possibility of developing breast cancer within a woman's lifetime if they take the combined pill for long periods of time within that their fertile lifetime, if you like. So if we're looking at a lower dose as possible, then that is probably the healthiest choice. Sorry, Karen.
No, that's fine. I thought I'd give you a little chance to breathe and have a
Yes,
drink of
thank
water.
you.
Just while I've been answering the questions that I can in the
Thank
chat.
you.
So a lot of
Thank
them
you.
have been things like resources. So
Yep.
I have uploaded everything possible.
Okay.
But there's one question that needs your expertise now from Oma. And the query is, can a woman take less than 21 days when on combined contraception if their natural cycle is 24 days and they experience bleeding on 17 or
Yeah,
18th tablet, i.e. take 17 tablets and then have a gap?
I mean, I think it's a tricky one, isn't it, really? Because if as long as you've taken 7 tablets before your gap, you are protected because we know it takes 7 days to put the ovaries to sleep. If I'm talking as I would, so we know. And then and any other pill, combined pill that you take after the 7 days keeps them in that state.
Yeah.
So in theory, yes, but I ideally I would question why they're having that bleeding if they're taking their pill correctly and it's a combined pill, because it's unusual to still be having breakthrough bleeding, and I'd want to
Yeah.
question why, because with the ovaries are asleep, so they're not going to ovulate, they're not having their normal cycle. So yeah, I would want to ask a few more questions around that. So it isn't generally something that we would do. We'd try and, well, should we up the estrogen a little bit? Is there something going on there that's making that breakthrough bleeding? Does that make sense? Sorry.
I'm hoping so. Hoping
Happy to
that's answered
discuss.
Oma's question, that if they are experiencing bleeding, even if their natural cycle was shorter than 28 days, they
Yep.
shouldn't be having breakthrough bleeding
No, no.
once they've passed 7 days. So
Yeah, yeah.
yeah, okay. I think
But
that's it. Yeah, we want to
okay.
know why and perhaps look at Yeah, okay, it does answer the question.
Oh,
Thanks, Anna.
brilliant.
Okay,
Brilliant. Yeah.
Sue.
No, no, that's absolutely fine. Thank you. I just needed a
And
brief.
just so that you can have another couple of minutes, I've uploaded the MEREC thing as we discussed. I've uploaded the leaflets around the weight loss injections, the link to that, and I've also uploaded the service specification, which covers off Mandeep's question about doing a BP and BMI for repeat supplies.
Fabulous. Thank you. So are you doing that then? Are
Yeah,
you
I've done
doing?
all of
Yeah,
that.
yeah.
I've done all
No,
of that.
sorry. Within the clinic, you would be doing blood pressure
Yeah.
within the. Yeah,
It's
fabulous.
in the
No,
service specification that the
fabulous.
BMI and BP must be checked at each supply.
Fabulous. Thank you. Brilliant.
Okay.
Yeah. Lovely. Thanks, Karen. Sorry, I know it's. I think it's good just to have a break from my slightly northern voice. I think, isn't it? Just really listening to me all the time. But yeah. So we have a massive choice of pills to start with, and some people have their own favourites to start. I would. For me personally, I always start with a 30 microgram because I think it's middle of the road. We can go down to a 20 and we can go up a little bit if we needed to. So I think from that sort of sensible um, synopsis for myself, that's how I think about that. And I think we're looking at safety. That's how we want to start with when we start the combined pill. We've taken a history from them. We've assured ourselves as much as we can that this is going to be safe for this individual, but let's just try and get to the safest method as well. So for myself, I would go for microgynon 30 or the equivalent now, which it can be Levest or Rigividon, because that is one of our oldest combined pills. I think we've had this around for at least 40, 50 years now. So we know an awful lot about it. It's known to, because it's got levonorgestrel as its progestogen, I know that that's a least hazardous progestogen in relation to the combination of the estrogen and progestogen for deep vein thrombosis and pulmonary embolism. There's an slightly increased risk, but it's not as high as some of the newer pills, although still that's relatively low. So for me, it's one of the safest combined pills that we can start somebody on as a starter pill. And then we go with how that works for that individual. And some people, they can find that the Millanet might be more is better skin friendly, and so you can start once. Again, it would be that 3 months starting. When they come back, we check their blood pressure because we know that the combined pill can increase that by 10%. So let's have a look what impact's been there. And then talking to the individual, how is it going? What happened? And then that's when these issues can be raised. Oh, I've noticed my skin's changed, or my mood's changed, or it's not happening for me. My boobs are really tender. They will come with those questions. I would suggest that the majority of people go, actually, it's really good. I've settled with it. I'm getting on with it really well. And so then we can just repeat them. If not, then you can look at what those symptoms were. Were they more prostrogenic, like the mood changes, like the weight change? Should we change the type of progestogen that's in there? And you can just, the faculty do have some information around that. We used to have a really healthy, really good list of what the different symptoms may be related to and what might help. So I will see if I can dig that out and send that across to Karen. But that's quite useful as well. And it's the different regimes to suit the patient. I think they don't, and it's quite difficult when the patient information leaflet of the pills still has the traditional way of taking the pill, because that's what they're licensed for, and it will cost a lot of money, I'm supposing, for them to change that. But I hope they do moving forward. If we've got 1 in 5 women whose ovaries may well start to have some activity during their 7-day break, which may lead to unplanned pregnancy, even though they've taken the pill how we've told them to take it. Things do need to change. But with ourselves in clinic, we do offer them these different ways of taking the regimes, and it's to suit them. So if they want to take the traditional, take it for 21 days and have a 7-day break, we would recommend reducing that down to 4 days. But they don't have to have that break. If that break interferes with their going away, or they find that during that time they get headaches when they're on their pill-free break, then try cycle it. Take it for the 3 packs and then have your 4-day break. Or the other option is that you just take it continually. So you take the combined pill continually, and then if you start with a breakthrough bleed, you have your 4-day break. It takes some confidence for them to take that control, but we've got a handy little booklet that they have. So initially, I think for most people they would start on the traditional method, just with the shortened pill-free break, and then once they get a bit cleverer with it, they start to feel more comfortable, then they may well start tricycling, and then they end up with just 4 bleeds a year, which is fantastic for some people. And then we would go through the missed pill guidance. And again, that can be quite complex, depending on where they are in the cycle of where they've taken a pill. So if they miss a pill within that first 7 days of their break, or the first 7 days of them starting the pill for the first time, they are in effect extending that pill-free interval, so allowing some ovarian activity. So the first week of their pack and their last week of their pack are the most hazardous times to miss pills, because in effect you're extending the pill-free break. So for some women, if they miss a pill in their last 7 days, we would say, well, you don't have to have an emergency contraception. Take the one you've just missed, but don't have your pill-free break this time, so that then they're not going to extend that pill-free break. Because with the combined pill, you could miss 2 pills in your pack and not be at risk, obviously depending where you are in your cycle. So sometimes that just takes a little bit of unpicking, and again, the missed pill guidance is on the faculty that Karen shared. And the risks and benefits, loads of benefits. And I think we don't shout these enough, especially with our young. Sorry, Karen.
That's all right. I'm coming in again. Just Vimal's
Yeah,
asked a
that's
very
it.
good question about the service specification. So he's saying in the PGD, can you supply off license, and can you recommend tricycling? And yes, I have attached the service specification, which includes the PGD, in the chat, and it does allow for the off license use. Because I know this came up at one of the face-to-face ones we had last year. So I went away and checked, and yes, you can supply these alternative ways other than the traditional 3 weeks on and 1 week off.
Yeah, it would just be really helpful if they change that information leaflet, wouldn't it? Inside the
Yeah, I mean,
pills.
unfortunately, you can't change a leaflet that is
No,
different to what's licensed,
no,
and so that's
no,
where it gets tricky.
it is
But you can have a PGD for off-license use. So
fabulous.
the current PGD does allow that.
Fabulous. That's brilliant news. Thank you,
Okay.
Karen. Thank you. And so I think with our young people, that we see our young women, and I'm speaking from the side of a sexual health service, as in they've come because they've got an STI, and they've come to see us, and we'll ask about contraceptive methods, and I can't take the pill, my sister can't take it because she gets, you get all of this rhetoric coming, and like on social media, I've heard it's really bad for you. So you're using condoms, but obviously they're not, because they've got an STI. So I think we've got a cohort of young people, especially, I'm picking on them, I don't mean to, but who are trying to do the best for their health, but in the same way they're putting their health at risk in other ways. So I think we're shouting the benefits, and I know at the moment we're putting out a social media post around this, acknowledging what their concerns are, but then also saying, well, actually, you're telling us your periods are really heavy, they're really this, they're really that. These are the benefits of these methods. And of course, there's risks, but they're measured risks. And the risk of a deep vein thrombosis in pregnancy massively immediately postnatal period massively outweighs the risk of using combined pills. And yes, there is a small increased risk of breast cancer, but after 5 years of stopping that method, then that risk goes back as though you've never taken it. And so it's having these discussions and just giving the information. So yes, I've got all the benefits are listed there, so I won't bore you by going through them. But I think this is quite important for us to sort of really shout these benefits to the individuals, especially not be getting pregnant. So I've got a little bit at the bottom that says quiz. We did this face to face last time, and I did have some quizzes, but I haven't done that this time because I didn't know how it would work virtually. So what I wanted to do, and I apologise for sort of showcasing other bits that we do, but I really do think this is a really important area for the community pharmacists to be aware of is our concerns around HIV diagnosis and the shift in demographics and the increase in late diagnosis of HIV. This is our latest data, even though it does say 2023. But there has been a big shift in the demographic of people who are being diagnosed now with HIV. I know this is a very busy slide and I will share them, but heterosexual contact is now the main reason for HIV exposure. And in 2023, it was 72%. It wouldn't surprise me if next time these figures are released, it will be higher. And men who have sex with men, it's 25%. Now, if we'd have done these slides 5, 6 years ago, that would have been a completely different picture. And there's probably lots of reasons for that. I think the invent of PrEP, pre-exposure prophylaxis for men who have sex with men or anybody who feels they're at risk of HIV transmission it's been another sexual revolution, if you like. You know, these people are no longer being at risk of HIV. So that is something to be really applauded. But it has seen this shift. And the most common ethnicity, 44%, is Black African, followed by 41% white. So I think there has been this shift in HIV diagnosis, and these are the ones in Essex, as well as nationally. This is a national picture. And although our numbers in Essex are small, and I'll move on to the next slide for that, you can see, I know this slide is really, really difficult, but you can see the sort of new diagnosis, and you can see how it is coming up. Now, the blue, so the darker one, this is the diagnosis of people who have come into Essex, but they were diagnosed abroad with their HIV. So they've appeared in the country with an HIV diagnosis. But even so, people who have been diagnosed within the UK, it's not dropping off, and there's certainly been the spike since COVID. And we can see that there's been a spike in 2021, and although it's dipped down a little bit, it's still uncomfortably high that 50% of new HIV diagnosis is actually diagnosed late. And this, we believe, is partly due to the change in demographics, as well as people coming in from abroad. These may well be related to some type of legal or illegal immigration into the country. Their HIV medication, they may have not arrived in the country with enough. They may have been taking other type of medication that's available abroad, which is very old now in compared to the medication that you can receive in the UK. So these people are presenting to the HIV services quite poorly. They've got very low CD4 counts, and this is why we're getting this shift in data. But certainly within Essex, sorry, Karen.
That's all right. It's something I'm really interested in. Are we seeing increases in TB in these people as well? Because I know, probably going back about 20 years, in East London, we did a lot of work on co-testing HIV and TB and found that the two, whether it's the low CD4 count was causing latent TB to become active, or when we were finding people testing positive for TB, the reason for it was a low CD4 count. So I just wondered if we're doing joint testing at the moment.
We're not doing joint testing at the moment, but it's really interesting you're mentioning that, because I think one of the reasons I wanted to present this today is that we are at the moment having a project with the HIV team, and we're having people sharing their stories of their late diagnosis, and this is predominantly in the Essex area, of being people you wouldn't think were at risk of HIV, and it's that whole who is at risk of HIV. So these are women in their 50s, heterosexual white women, who the last thing we're going to talk to them about is their sex lives or whether they've been put at risk of HIV. And they're presenting repeatedly to their GP and to the health professionals with strange presentations. And I suspect TB may well be one of them that they're being admitted to hospital with. But it could be shingles in some repeat that you weren't expecting, or strange infections that women, and the last thing they're being asked is, when did you last have sex? Or do you get tested for STIs? So we are going to share that video with professionals, and certainly, Karen, I'll be sharing it with your teams as well, because I think it's a massive eye opener for us all, and we're just as in that space as well of making presumptions about people because of how they present. And certainly my colleague who works, Selena, in the HIV service in Chelmsford, the majority of the people she sees with new diagnosis are from a white demographic and heterosexual and women. Yeah, so it's a big shift. But with the new, opt out of HIV testing that's about to start in our accident emergency departments, I think we're going to see a big increase in new HIV diagnosis, but hopefully at an earlier stage. So that hopefully comes into place very soon. So that's good.
No, I was just interested about the TB because, I always think nobody ever has just one thing.
No,
and
no.
It was quite interesting in East London to look at the relationship between the two.
Yeah. I think that's really a really valid point, and I'm sure that's something that they will see in the hospitals with that diagnosis. I still think it's the last thing they think of. We hear it time and time again when we're listening to these stories that it was they went, oh, shall we just do a HIV? And it was the last thing, and they may well have been in ICU at that point, and did a HIV test. Lovely. Thankfully, not very frequent, but something to be aware of. So, and these are just some local figures, and of course I'll share them because they're really complicated yeah. But we can see here quite clearly the late sort of diagnosis that's showing up there within the county, and sort of the highlighted areas that we're seeing the increases in diagnosis.
Sorry, just jumping in again there, and this is one for colleagues on the call. Bear in mind, this is the Essex Sexual Health Service, so if you're in Southend or Thurrock, your data won't be included in this, but
no, it's very similar.
That data, yeah.
I did see all of it at one, and it's an Essex wide, it's a national situation, and it was quite interesting. Our outreach and health promotion teams have actually been asked to go and work within some of the local care homes, and it's sort of because people are getting older with HIV, the treatment for HIV is so effective now. It is not going to be the condition, hopefully, that you're going to die from. You're going to live a long life with HIV. So you're living with HIV and it's going to be well controlled, but you are going to develop other health conditions, which may, as people get older, end up being in care homes. So it's education for around care staff, but it's also recognizing that some of our immigrant population do go and work in care homes who may well be HIV positive, but they do not want to disclose because they don't understand our health service or that care's free. And we do have some posters that I can send to Karen just to sort of publicise the fact that all of our HIV services are free in the UK. So, and this is one of our new posters, which we are sending out to yourself. So I hope you will be able to share these within your pharmacies. And I think it's just sort of rethinking the testing. The picture has changed, and even for professionals like ourselves, it's a bit of a surprise. I'm slightly guilty of this one because we tried to have it as a Jackie magazine cover. Only people of a certain age will remember Jackie, but it certainly was where myself and my cohort and young. Thank you, Karen. I don't feel like the only dinosaur. Not that you're a dinosaur, but I certainly am. And just that's how we learnt about relationships, And so we had this little thing really because older women will just think, well, it's okay. I don't have to I won't get pregnant. And that's one of the benefits of going through the menopause and our new stage of life. But, it doesn't stop STIs coming through. And I think I've put this up as well because I know a lot of the pharmacies are C-card outlets and assessors. And I think this goes alongside that contraception assessment and supply is, especially for the under 25s, is you can get free condoms. And again, it's like opening that conversation of it doesn't supply everything. I think I've probably gone and added more slides than I needed to. So I'm just going to skip through a few of these. Oh, the personal health record. So I know at the moment pharmacies don't have access to STI testing, and it is something that we are working really hard at how we're going to do this so that we can link in with yourselves and you have a supply of our test kits and you can scan that with a barcode and hand that over to the individual so that we have both of our services have record of that data. So we are working really hard with that. At the moment, the only way to access free STI screening within Essex is through the personal health record. I know our colleagues in Southend and Thurrock, they use SH24. We have this Click It test, which is through this personal health record. So it's an online portal, you download the app. Well, it's not quite an app. I got told off for saying that. It's this portal, online portal, but you can access it on your phone and you're able to book appointments with our service. You're able to access lots of valuable information, but most importantly, you can order self-testing kits as well. And that's it. Over to you. I'm sorry it's been a bit full on and me talking all the time, but I'm happy to, if there is any questions, I'm happy to discuss that, or I know Karen's been answering them as well, so it's fine.
So if anyone does have any questions, there's a quick chance now to pop them in the chat. And then I'm just going to do a bit of a plug here, as well as the National Contraception Service. If you are taking that up for the first time and you don't currently offer the locally commissioned emergency contraception service, it does make sense to sign up for both, because you won't have to do 2 lots of training. The training applies for both. And we have had some really positive conversations with the Essex Sexual Health Service. So we are getting the PGDs for the emergency contraception service redrafted so registered technicians can supply emergency contraception. And as Sue mentioned at the start, you might not have the luxury of waiting for a particular gender to provide the service for the nationally commissioned service, but you may be able to offer that for the locally commissioned service. The other thing that we've done is remove the upper age limit. So instead of it being for 19 and unders, we've had a conversation with Provide CIC, and we've actually lifted the upper age limit. So that's more about creating capacity in the clinic setting rather than being nice to community pharmacies, but that's a nice little extra advantage. So the slice of the pie has got quite a bit bigger, and it does make sense to do both. And then tied in with that contract is the C card distribution, the condom distribution service. So do get in touch with us if you don't currently provide that service and you want to. We manage that from the office, so just contact myself or Angela and we can get the contract sent out to you. And then it is a nice opportunity for if you've got somebody that comes in and the reason they need emergency contraception is they've run out of their regular pill, is obviously you're then in a good position to recruit them to both services. So you know, you're upselling and you're increasing your service income. And as we like to say, all service income is profit. It's not dependent on the cost of medicine. So you've got a real opportunity there. And I am about to re-record the EHC webinar that we did in-house. Unfortunately, our recording failed, so I need to redo that. Hi, Chris. Good to see you join the call. And yeah, we've already agreed. Sue's going to share the slides with me, so we'll make those available to you early in the week. Have we got any other questions? Apparently, I'm not supposed to say, are there any questions? Because people feel challenged by that. Apparently, the way we're supposed to put it to you is, what questions have you got? And that's supposed to make you feel more comfortable to ask them. If you do think of anything later on, just pop it in a WhatsApp or pop it in an email. And I'm sure if it's something about resources and links and things, we can do that from the office. If it's something a bit more clinical, then I can ping it across to Sue for any specific issues that might crop up. But I think we might be able to stop at 12:30, Sue. So sorry everyone that's missed the Archers Omnibus, because I know that's what you all spend your Sundays doing. But there is a good opportunity. There is a separate EHC PGD for Thurrock, which we're working with Thurrock Council on. So at the moment, it doesn't apply to Thurrock pharmacies, but we are working with Thurrock to get a PGD service down there. So we've got one in Southend, we've got one in Essex. Thurrock have just engaged Brooke to manage their sexual health service, and we're just finalising the details there. Okay.
Thank you. Thank you for the opportunity. We always like to have a chit chat about contraception and sexual health. It's like,
And there's a nice bit of feedback for you there from Catherine to say that it's been fascinating and informative, and a thank you from Oma as well. So, we're getting lots of thank yous now. Now they're going to compete now. They're going to see who can give the best thank you.
No, it's sweet because, you know, without the community pharmacies taking on these, you know, I think we can't cope. Is that, am I allowed to say that? We can't give the service we want to give because people are having to wait too long. And so it's just a win-win for everyone, really, isn't it? It allows us to sort of concentrate on the more complex cases or do coils and all the rest of those things. And it's just brilliant that we can all work together. Well, you never know. You never know what we might ask next. Certainly implants. I don't know why you can't do implants.
Definitely. Yes. Yeah. And just to mention before you all drop off, because I know you're about to, Vimal, if you just contact us for the emergency contraception, drop us an email on tomorrow, just drop one for me and I'll pass it to, and I'm glad we've worked out how Stephen listens to the Archers. He listens live. Just to mention as well, we are working with our provider company Safeguarding Lead, is pulling together a community pharmacy safeguarding webinar that we'll be running in the next couple of months, looking in particular at the current issues in Essex with domestic violence, suicide prevention and safeguarding, which I won't say it's a party night, but it is a very important webinar, and it is stuff that we need to be aware of, because in community pharmacy we'll often see people that are trying to evade other services but who do still need help. So keep an eye out for that one, which will support the contraception service. It will support the sexual health service, because that's often related, and you will see people trying to access contraception in some straitened circumstances. And yes, I will send through, I'll record the chat, and so Vimal and Sala, I've noted that you want the links through for the emergency contraception. That's fine. In the nicest possible way. I'm not doing any admin work on a Sunday, but we'll get that out to you early in the week. Okay, well, thank you again, Sue. I hope you have a nice afternoon. I hope it
You
doesn't
all too.
actually rain.
It's going to.
Yeah, Navin, if you do get any complex questions, I suggest come through to us. We have recorded this webinar, but I need to have a chat with Sue about whether she's happy if we put it on our restricted website or not. Okay.
Lovely, thank you. And if anybody does want to pop to their local sexual health service and have a look round and chat to the colleagues, we'd be more than happy to have people popping in.
Yeah. Okay, and noted, Chris, we do try, mostly we do things during the week, and we do try and avoid Sundays where we can. It's always going to be a rotational job, unfortunately, but you know, we do try and chop and change between evenings and weekends for any of our updates, as you know. Okay, well, if that's it, Sue. Thank you very much.
Lovely, thank you.
I'll give you the
Lovely
rest
to
of
see
your
everyone.
weekend back. Nice
Thank
to
you.
see so many of you in the call. We
I
hit
know,
65 in
brilliant.
the end.
Woo.
So well done, and speak to you all soon.
Lovely.
Okay,
Thank
then
you.
I'm now going to
Bye.
close the meeting. Thanks, everyone.
Bye-bye.
Bye.
Bye-bye.